How's that? I think I unmuted it. Did that seem to work? Okay, good. One of the things I thought about when I was thinking about this talk is that, you know, in my world, we are typically scheduled patients every 15 minutes. And those patients are usually coming in for, say, an annual exam or some sort of physical complaint, and almost nobody makes the appointment saying sexual problems. And so, you know, in a 20-minute time span, we are, as gynecologists, trying to go through preventative health and, you know, do you have a primary care doctor, and what are you doing about cardiovascular health, and do you have birth control? And so when this question comes up, as you all know, this is not an easy 5-minute conversation. So I've had to kind of, in my own practice, figure out how can I distill this down to where I can have some meaningful conversation and at least start the process with the patient, because it usually just comes up out of the blue in the middle of the visit. So this is sort of a typical example of what would happen in my office, is that I would be up all night with not anymore because I don't do obstetrics anymore, but I'd be up all night with somebody in labor, and I wouldn't get any sleep. And then I'd be rushing to the office, and I walk in, and, you know, this is supposed to be a visit for irregular periods, and I'm taking the history, and the patient doesn't have any sexually transmitted diseases. And, you know, and I'm thinking this is going to be a pretty straightforward visit. But then what happens is she says, I just have no libido, and I want to talk about that too. And this is what I'm thinking. Oh, great. Okay, well, we only have about 10 minutes left in this visit, so I'm sure we'll make a lot of progress. But so that's the situation I find myself in literally almost every day. And so I give this talk also to the University of Tennessee residents who we work with, because in residency, and this was true of my residency, we really get almost no training in sexual dysfunction, sexual trauma, other than the physical aspects, right? We get taught how to, you know, process somebody who has unfortunately been a victim of rape, or, you know, how to screen for sexually transmitted infections from something that happens. But we don't get a whole lot of education on just the range of what's within that sexual dysfunction category. And if we think about 50% of women having some kind of sexual dysfunction, I mean, that's obviously a lot of patients. And I definitely see that in my practice. So it's a difficult thing to talk about, a sexual history. I mean, a lot of patients have these problems and don't bring them up. And so I find that you have to poke around a little bit if you want to get into this topic with a patient. I mean, you have to ask some, you know, kind of difficult and embarrassing questions. And even the ones that come with this complaint have a hard time always talking about everything related to what their concerns are. And I would say from a gynecologist standpoint, rarely is the physical exam helpful. Most patients that we are dealing with don't have anything physically wrong with them when it comes to their sexual health. And so, and same thing with laboratory evaluation. And I'll get into some particular circumstances where there are some things, but in general, that's not going to be super helpful. And I think the bigger thing is not making any assumptions. You know, gender identity, sexual orientation, those are things that I know in my own practice, I've struggled with what's the best way to get that information. You know, I tried for a while having a question on my intake form, but people would leave it blank, or they would, you know, not really completely answer that. I just found that to be not very helpful. And then it's interesting when you ask people directly, there's sort of a range of response and comfort level. You know, some people are quite open about that. Others are very, you know, guarded about that. And so it's just a topic that can be hard for in the medical world. And I think a lot of times people, when they're coming for a medical visit, that's not something they're really always prepared to talk about, even though, and I think as in OBGYN, because our whole our whole training surrounds the organs that you use for sex. On the opposite side, people think, oh, well, we're an expert, we just know everything about that. But that's not really the case. We know everything about the physical ailments, but we don't always know about some of these other things. And then I have found too, you have to be very direct about the types of intercourse. So we have a question on our intake form that says, are you sexually active? Do you have intercourse? Well, when I was very early on in my practice, for example, with teenagers, I would find they would put no, because they were thinking of that as vaginal intercourse. But if I actually asked a little bit more, it turned out some of them were having anal intercourse, or some of them were having other types of sexual activity that they just, so that's another thing. Just over the years, I've learned to be a little bit more direct about. So these are sort of the minimum questions that I try to ask. Do you consider yourself sexually active? Do you have any partners? How many do you have? And it's really hard actually to create a feeling of comfort and openness, because a lot of my patients, I might be seeing them for the first time. I only see them once a year. And so getting the trust for them to kind of open up about those things is difficult in a 15 to 20 minute visit. But these are the things I try to at least make sure I hit on. And, I would say we try to always ask about sexual trauma, but again, as y'all know, people can be very guarded, but I try to look for other clues in their history. For example, if somebody has a lot of psychiatric diagnoses, a lot of those things are comorbid. So, I might make a little bit more sure I ask some questions about that. Or I've sometimes seen patients who they say they have no past medical history. And then when I go to do the exam, I see scarring from cutting on, different parts of their body. And then I think, okay, we probably need to try to dig a little deeper here and see if there's something else going on. And honestly, many times people will come and say they have no libido or sex is painful. And, you're asking all these questions about the physical part. And then as you're asking, you're sort of getting the feeling that, well, it's really not painful. They are just afraid to have sex, or they've had a bad experience, or they've, so that's, kind of where I go with that. And then if I'm trying to dig a little deeper, then I'm asking things like, well, how long have you been together, and what types of sex do you have? A really big one is, do you have an orgasm? I'll have lots of patients that say they have no libido, but when I get in deeper, everything's fine. They just never have had an orgasm. And then I'll think, okay, well, I don't know that you have dysfunction necessarily. You just don't find any enjoyment in it. So you have no drive to go do it. So maybe we need to work on the orgasm part, because if we could fix that, it would kind of take care of itself. And so, masturbation is a difficult thing to ask people about, but it's really important. I mean, a lot of women have never had an orgasm, and so they don't even know what they're trying to do. Anything about sex is painful. And then any medications that could affect sexual dysfunction. So we all know that a lot of the psychiatric medications, that's a big side effect. And so, but we have to take that into account as well. Some of the beta blocker medications, or sometimes their spouse is taking a medication that affects their sexual dysfunction, and that's creating some of the issue. So in my head, when I'm seeing this patient, I sort of think about what category they fit into, and then that helps me sort of think about, well, what questions do I need to ask, or what do I need to focus on? So this is how I think of it in my head. Teenagers, reproductive age, married, 20, 30 years versus single, having multiple partners, same-sex relationships, menopausal women, and cancer survivors, particularly breast cancer survivors, because they have some limitations on what they can do with hormone therapy. And I think the same-sex relationship thing is kind of interesting, because I think that there's less discussion among providers in the medical community about that. I mean, I think a lot of people make assumptions that that those people are very sexually active and everything must be fine, but in reality, they have just as many sexual problems as heterosexual couples. So teenagers, again, this is what I talked about before. You have to be very specific about what you're asking. They're very literal. The big focus for them is on, HPV vaccination, STD prevention. They don't really have a lot of sexual dysfunction. Like, in fact, if I see somebody who's in their early 20s and they're complaining about low libido, to me, that's sort of a red flag that we need to talk a little bit more about that, because that's not a very common complaint in that population. They're sort of a major population to be screening for partner abuse, sexual abuse, history of abuse, and then they can have some physical issues. So imperforate hymen is one that sometimes people forget to think about, but when women are when the vagina is being created, there's a membrane that forms over the opening to the vagina, and then what it's supposed to do is dissolve and go away and leave that opening to the vagina. And in some patients, it doesn't dissolve at all, or it may partially dissolve. So you could have an opening with half a membrane covering, or you could have an opening with several little tiny openings in it, but not a big opening. And so those girls will be menstruating and blood is coming out and everything seems normal. But when you ask them, they can't get a tampon in, or maybe they've gotten a tampon in and can get it out, but they've, and so they go to have intercourse and they're having all this pain and they don't know why. And, come to find out, oh, well, this is why. And that's a outpatient surgical correction. It's very easy to do, but that sometimes is how they find out that they have that. And then reproductive age women. So this is the population where I see the most dysfunction. And in my population in private practice, what I mostly see is libido being the main complaint. And, a lot of these people are in long-term relationships. So then you're having to ask, are there other factors involved? Is the relationship at risk? Is that, what's going on? Are there other relationships going on, on the sidelines? And that's factoring in. I had one patient who came and had no libido with her husband. And long story short, it turned out she had had an affair with her personal trainer and, had ended it anyway. So there was a lot more going on than just like, I don't want to have sex with my husband. And then partner expectations. So sometimes we talk about, how often do you have sex? How often would you like to have sex? How often does your partner want to have sex? Because what's going on for you may not be abnormal. You may just have a mismatch. One partner wants sex more than the other. That doesn't mean there's necessarily something wrong with you. It just, you've got to talk about expectations and, so sometimes just trying to reassure people that actually they don't have anything wrong with them. They just, need to maybe have more discussion about what they're expecting. Multiple partners, obviously our big concern there is infection. And so that's something that we talk about, but also, sexual abuse. And interestingly, libido may or may not be a problem. I mean, just because somebody's having a lot of sex doesn't mean they have a strong desire to have sex. They might be having sex for other reasons, or, so just not making the assumption that just because somebody's sexually active, they don't have any sexual dysfunction. Same-sex relationships, we kind of talked about this already. Menopausal women. So this has been really eye-opening for me now that I'm in just gynecology practice, because I see so many more older women. And one thing that's been very interesting is a lot of these women don't want to talk about it. And then if you get them to talk about it, what you find is it's not that they don't want to have sex, it's that it hurts to have sex. And when women go through menopause and they no longer have any estrogen, the tissues of the vagina get very thin and very tender and quite painful and can even tear or rip. And so they'll just stop having sex. And so have had so many women who come in, and if I ask them about sex, oh, well, I don't have sex anymore because, it just hurts too much. Okay, well, we could fix that. And then, and you could go on to have sex, and that, so that's a good example of when there's a physical issue. And hormonal status, that's that lack of estrogen. And one thing that I always point out is a lot of these women, they don't want to be on hormone replacement. They're worried about the risk of breast cancer. They're worried about other cancers, or they're worried they're going to get a blood clot, or they're worried about the medication. And I try to give them the example that vaginal estrogen is like putting hydrocortisone cream on a mosquito bite. You're not taking steroids. You're putting steroids on your skin. You're treating the skin at a topical level. You're not absorbing that medication and systemically exposing yourself. Just like when you put that hydrocortisone on, you're not taking steroids throughout your whole body. You're just putting it on the surface. And I find that has been really helpful in having them feel more comfortable about using that, because vaginal estrogens do not systemically expose women to hormone therapy. So just something to keep in mind as you see patients in this population. And that leads me always to the cancer survivors. So breast cancer, we are getting better and better about treating breast cancer, which is fantastic. I think it's something like 90%, or maybe 95% of stage 1 breast cancers, people go on, live healthy, normal lives. The problem is that breast cancer has been, there's a lot of time spent talking about whether breast cancer is estrogen receptor positive or progesterone receptor positive, and whether hormones promote breast cancer or promote recurrence, and so a lot of these women are told they can't have any hormones. And I won't get into that whole debate, but a lot of them are told they can't have vaginal estrogen because it's an estrogen. But the reality is, and there are great studies, and if anybody's interested, I can send them to you, but that have looked at the circulating levels of estrogen with topical vaginal estrogen use, and it's undetectable. And so a lot of these women are suffering. They're not having healthy sex lives. Their sex is painful, and they're 48 years old, 52 years old, 60 years old. And so anyway, so that's a population that I try very hard to talk to. And a lot of the oncologists in town are getting better at accepting vaginal estrogen. There was a long period of time where you could not get any oncologist to sign off on any estrogen of any type for their patient that had breast cancer. But that's gotten a lot better. But there's still that mindset kind of for a lot of people that you're just told you just can't have it at all. And then, so when I do the physical exam on these patients, these are the kind of the things I look for. And like I said, a lot of time, overwhelmingly, you're not going to find anything. Everything is going to be completely normal. And of course, reassuring them that everything's completely normal is very important. But some patients will have prolapse. So that's when the organs, the female organs, are kind of falling down and out of the pelvis. So, and there are many things that go into that: childbirth and the trauma from babies coming out of the vagina, age, collagen breaks down as you get older, everything gets a little bit more lax. Genetically, some people have more lax connective tissue, people who are smokers. Anyway, all those things kind of contribute to that. And prolapse, because there's an anatomic distortion, sometimes women are they're not having sex because they're embarrassed or because it's uncomfortable because of that. And so that's a very important thing to identify. Endometriosis, so that goes along with more the pain with intercourse. Hypertonicity of pelvic floor muscles. So people who have been victims of sexual trauma will often have this. The pelvis, if you look at an anatomic picture of just the muscles, it looks like a bowl with sling muscles. So if you can picture like the pubic bone and then muscles coming around like a sling, and it just looks like a bowl of muscles. Well, just like any other part of your body, if you think something's going to hurt or something's hurt in the past, the first thing you do is clench like this. And if you're doing that all the time or frequently or every time you have intercourse, pretty soon that becomes like a learned pathway where the minute you think you're going to have sex, everything tightens up. And so we have really good pelvic floor physical therapists in town that work with patients on this. They're really great. And, you know, they do a lot of just mind body work and then some targeted physical therapy. Sometimes we even use, in conjunction with that, we can do like a compounded Valium suppository and all kinds of other things. So that's something that can be very helpful. There, I didn't put this on there, but there's something called Vaginismus, which is sort of a similar type thing, but where the vagina actually sort of cinches down. You can think of, and so people can't even have penetrative intercourse. And pelvic floor therapy can be very helpful with that as well. Other things I'm looking for are evidence of low estrogen, so sparse pubic hair, hypoestrogenized vagina, pain in certain areas of the pelvic floor. I've had some patients where we've done lidocaine injections to try, almost like a nerve block. I've had other patients we've tried doing Botox to try to loosen those muscles and relax some of those muscles. And then vulvar vestibulitis is something that it used to be treated with something called a vestibulectomy, which fortunately I haven't seen in a really long time. But when I was in residency, that was something where people actually surgically went in and removed these introital area of the vagina. I think we've since found there are a lot of better ways to deal with that than a surgical removal of tissue, but you may see that if you're looking up some of the literature in this. So libido. So what's normal? And that normal, I always tell, I mean, that's impossible to define, right? It's whatever's normal for you. And there's a really big wide range. And, you know, I try to break things down into the biological factors, the psychological factors, and then social factors. And because that way I can think about, well, what piece of this are we having impact on? So from a biological standpoint, hormonally, testosterone and dopamine are sort of your big drivers, but also estrogen and then oxytocin. Oxytocin is the chemical that makes your uterus contract. It promotes, you know, feelings of well-being. Testosterone, so all women make testosterone, just not as much as men, obviously. And it's actually one of the hormones that the ovaries continue to make even after menopause. Granted, it just like in men, it starts decreasing over time, but even women in menopause still, who have their ovaries still, may be making a small amount of testosterone. The anti-libido hormones, progesterone and serotonin. So this is where we're at odds with some of our medicines. So I always like this graph. I use it a lot with my patients because I feel like it kind of sums up everything. And actually a lot of women don't understand what hormones happen when and what goes up, what comes down. And it really, you can explain so many things just by looking at this visual. But so if you look at that middle part, you can see the blue line there is estradiol, and estradiol kind of goes up, peaks right before ovulation, comes down pretty dramatically after ovulation, gets this little slight bump up again, and then of course goes back down if somebody's not pregnant. And then progesterone is that black line. So it's pretty low until after ovulation, when the ovary, the area that produced the ovulated egg, makes progesterone to support the pregnancy until the placenta can take over, which is at about 10 to 12 weeks gestation. So that goes up. And then if you're not pregnant, of course, that little area in the ovary goes away and the progesterone comes down, and that's what triggers the bleeding. And so progesterone, you know, progestation, right? That's the pregnancy part of our hormones. And it actually can decrease orgasmic ability in a sense. And if you think about all this from a biologic standpoint, it kind of makes sense, right? You know, you ovulate, and then you want the egg to get fertilized, then you want the egg to implant. So maybe we're going to decrease our orgasmic contraction, which might disrupt the egg from implanting. That's how I kind of think about it. So medications with libido, these are the things that I'm looking for. So birth control pills are terrible for libido because birth control pills increase a protein called sex hormone binding globulin, which goes in and binds up all your free testosterone. So your testosterone levels drop when you're on birth control pills. Now, we like that because it makes your skin better. And, you know, if you have a little extra hair growth or you have PCOS or some of those things, makes all those things better. But the problem is, as your testosterone drops, so does your libido. So in those patients, we often will talk about something non-hormonal. Maybe they want to go to an IUD. Maybe they want to go to a progesterone IUD, something that doesn't do that. Maybe they'd be better off doing barrier methods like condoms or a diaphragm or something like that. So, you know, but you have to, of course, balance that with protecting them from pregnancy. The SSRIs, we all know that great side effect, decreased libido. The antipsychotics, opioids, beta blockers. So a lot of our older women will be on beta blockers for high blood pressure. And then, of course, substance use and abuse. So psychologic factors that impact libido. So levels of intimacy, stress, fatigue, distraction, depression, body image, sexual trauma. I would say in my population, I think that a lot of these things are kind of occurring in the context, in the reproductive age people. You'll see women who, you know, they've had 2 babies, they're working, they've gained 20 pounds because they're working and have had 2 babies. And all these things are kind of coming together to make them feel not sexy. And, you know, and then they feel like something's wrong with them because they don't feel this way. And so we spend a lot of time talking about, well, what are all the things that are going on in your life? And, you know, maybe there's really nothing wrong with you. Maybe we need to address some of these other things. And because of everybody, you know, is looking for that magic wand to wave over them and just poof, everything's good. Social factors, gender identity, sexual orientation, religious influence. I'll have patients that come from very religious backgrounds and they're very uncomfortable talking about any of these things. Infidelity, masturbation. So the disorders. So this is, I thought this was kind of a good breakdown. Hypoactive sexual desire disorder is probably the most common thing that I see. And then I would say dyspareunia. I don't see that much vaginismus. It's not all that common. Definitely, it would probably be more common in your populations that you're seeing that have that history of sexual trauma. Yeah, so prevalence is high. And once we're talking about that, I try to think about it like, is this a primary problem or a secondary problem? Meaning, you know, if you had this, has this always been an issue for you? Or, you know, sometimes I'll get, well, everything was fine until ... Doesn't occur in all situations with all partners, you know, so sometimes people feel this way, but they'll say, but, you know, when I had this relationship, I didn't have any problem with it. So that's something that I try to explore more. So hypoactive sexual desire disorder is really a giant category. I mean, and I personally don't really like to label people with this. I feel like, I don't know, that's just my personal opinion. I feel like giving them a diagnosis kind of feels, because it's such a broad range. So I try to stay away from saying like, oh, you have, you know, this disorder, and more just try to get into what's going on. Sex therapy is the counseling part. It's hard for people to do that. It's hard for them to have time. It's hard for them to find a provider. It's expensive. Insurance doesn't cover it. I mean, there's just so many barriers to that, I find. This is, so obviously exploring pornography is controversial, and obviously in certain populations, you got to worry about that becoming its own problem. So that wouldn't be high on my list. I do talk with my patients about masturbation, especially with women. I think giving them some empowerment there to like figure out how their body works and what works for them. And I think that goes a long way toward helping them feel better about themselves. And then medications. So I think I've spent some time, I spend some time later on talking about the medications because I find that part really interesting. But so sexual arousal disorder, absent or diminished feelings of sexual arousal. There actually is an FDA approved device for treatment for this. It's called the Eros. It's essentially, I don't know if you can see this very well, but it essentially has this little suction cup area, which is put on the clitoris. And then you press a button and it sucks the clitoris into the device and sort of vibrates around it. It's fairly expensive, probably not very, I think I've had one patient who's used this. But vibrators are really the most common thing. I actually go over with my patients, I pull up a website that has a bunch of vibrators because if you've never done that, it's incredibly intimidating. There are probably 6,000 different types, and some of them have all kinds of bells and whistles and appendages and funny shapes. And really, you don't need that. So I usually pull up that website and I'm like, let's look at this. Like, this is what you need. You need something very basic. It just needs to vibrate. That's it. It doesn't need extra things. This is a product that I find has worked really well, especially for my patients who've never had an orgasm, don't really know how to do that. This is, and there are lots of versions of this, but this particular one is made by a company called Lilo. And this device, this part of, I don't know, is my mouse up there? Oh, it is. So this part right here has a very light section that sucks the clitoris into it. And then the whole thing vibrates. And as you press harder, it vibrates harder. So people feel a lot more control with it. They don't feel like, this is like too much. So this is really good for people who are just kind of starting. They're not really sure what to do. It's a little bit easier. It also comes in an unmarked box. I always reassure them about that because they're very worried about how this is getting to their house. Then, so orgasmic disorders, masturbation, cognitive behavioral therapy, sensate therapy. These are all things you're familiar with. Sexual pain disorders. So I have found really good results with vaginal dilators, which have been around forever and are super cheap and give patients total control over how they progress with this. And I use this a lot, especially in people who are either financially unable or just unable to go to pelvic floor physical therapy. They don't want to, it's embarrassing, it's too much money, they don't have time, whatever. They can actually just do this on their own. And this is also a thing I pull up on the internet because, again, there's a whole price range, right? You don't want the cheapest one, you don't want the most expensive one, like somewhere in the range of $30, you can get a very decent set of these. And the way I have patients do this is I'll tell them, look, you're going to start with the smallest one. And when you go to bed at night, you're going to put it in and then you're going to read a book for, I don't know, 10, 15 minutes, 20 minutes, and you're going to leave it there because hopefully what's going to happen is you're going to get distracted and your body's going to relax around this. And it's going to stop perceiving that touch as noxious and, doing this. And then they can slowly, as they feel more comfortable, progress in size. And this is the cheapest, easiest treatment in the world for that problem. And I have some patients who, once they get to a point where they're comfortable with that, I'll say, okay, now you're going to have intercourse. So maybe 20, 30 minutes before you have intercourse, use the dilator, put the dilator in, relax around it, take a deep breath, recognize that doesn't hurt, and then I've had a lot of good success with that. So that is that's usually my first go-to with these patients. Testosterone is such a mixed bag. There are studies to say it works, studies to say it doesn't. The most common studied formulation is a 300 microgram patch. There is no FDA approved testosterone medication for women. There are FDA approved forms for men, obviously. And so when I use these medications, I'm either using a product that's FDA approved for men and we're modifying it, or quite often I'm doing a compounded cream or something that can be absorbed topically. It takes several weeks to see any effects. So you have to give good expectations of, this isn't going to be an overnight thing. You're going to need to do this probably for at least 2 months before you see anything. And you can do it as a cream. You can do it as an ointment. It really doesn't matter where you put it, but with any kind of topical absorbed product, you want to put it in a place that has thin skin because, so like the inside of your arm, the inside of your thigh, because the thinner the skin, the more you're going to absorb. I had one nurse practitioner who did a lot of sexual dysfunction stuff, and she would have it compounded in a oil base, and then had them rub it on their clitoris. And I thought that's genius because twofold. One, they're absorbing the medicine. Two, maybe that's helping them with some of that touch and stimulation. So that's an option also, but it really doesn't matter where you put it. The reported side effects of any like elevated testosterone level in your body are hirsutism, so extra hair growth, and acne. I've never seen that. I mean, we're talking when we're supplementing patients, we're not trying to get super therapeutic. We're if I said, okay, men's testosterone levels here and women's are here, like we're just trying to get here. You may have patients who go to these hormone replacement clinics where they do pellets and all kinds of stuff. And those patients will often get over replaced. They'll put testosterone pellets in, they last 3 months, and their level will, instead of being here, will be like here. And then they usually come to us because they'll say, I'm bleeding all the time and I'm breaking out and my skin's oily, and and there's really nothing you could do, just let it dissolve and just not do it again. But in the office, when we're trying to do it, we're just trying to bump them up a little bit. So I will do labs sometimes after I start it, just to make sure, are you even absorbing it? Because some people, they have really thick skin and it just doesn't get through there, or we need to do more. But I always think less is more with that than going way high. And I would say it's really, I have some patients who swear by it. I have other patients who feel like it does nothing. Unless they have some really big medical contraindication to doing it, it's always worth a try. I mean, I kind of just tell them, I can't promise you it's going to work, but I don't think it's going to hurt you. So if this is something you want to try, we can do it. And the fact that the long-term safety is unclear, in my opinion, this is such a small amount of supplementation. I'm not really that worried that we're contributing to cardiovascular risk or any of those things. So ADI is a medication that came out fairly recently. I mean, I think it was approved a while ago, but it only kind of commercially began being pushed in the past couple of years. And how it works, it increases dopamine and norepinephrine, and it decreases serotonin. So that's not so great for patients who already struggle with their serotonin levels. It was interesting. It was originally developed as an antidepressant, but then they found, oh, this doesn't work at all for this, but maybe it'll work for this. So it's kind of a medicine looking for an indication. And you have to take it every day, and you have to take it with food. And it's not a female Viagra, which is how a lot of people talked about it when it first came out. So Viagra you take and you have this effect and it lasts so long and then it goes away. This is a medication you have to take every single day for it to work. And you take it at bedtime, because if you take it during the day, it increases your risk for low blood pressure. So you can faint, which obviously you can hurt yourself. It increases your risk for depression. You cannot drink alcohol when you use this medicine. So this is sounding great, right? Like this is like totally what you want to do, is take a medicine every day for like the one time a week you have sex. And then you're supposed to discontinue if it doesn't work. And interestingly, it's not currently indicated in postmenopausal women. So it's just not a great drug. I've had probably just a handful of patients use it. I have had nobody yet who claims it's great. The side effects are really limiting, and that's usually why people discontinue it. I thought this was really interesting. So so per the data, there was a meta-analysis that showed that there were 0.5 more satisfying sexual encounters per month, which to me is very, very small. And so I just don't think that the side effects really justify the point. I don't even know what a 0.5 sexual encounter is, but that's what you get. And then I thought this was interesting. I'm going to read this because just so I get the details right. But so the approval was very controversial. So it was first submitted in 2009, but it was rejected because of the risks and the side effects. Then it was sold to another company who applied and again was rejected. And then in 2015, they resubmitted with no new data and they were approved. And then ironically, within 48 hours, they were sold to a different pharmaceutical company for about $1 billion. And there was also at the time a lot of activism around the fact that there were not as many drugs for women as compared to men for sexual dysfunction. And ironically, the campaign that was managing that activism was a public relations firm that received funding from Sprout. So there was all this like sort of, because when this came out, we were all sort of scratching our heads like, why did they approve? Like, this seems terrible, you know? But there you go, the politics. So there's another medication, Vyleesi. Nobody knows how it works, apparently. And it's an injection. So you have to inject yourself about 45 minutes before you have intercourse, and a little less than half the patients have nausea. So that, I'm sure that really helps. And it is, per the studies, it improves distress and increases feelings of desire, but it has no improvement in the number of satisfying sexual events. And it's got a risk of hypertension. So again, I mean, if taking a shot before you have sex sounds good, then I guess you could try this. But most of my patients, the minute I start saying, and you inject yourself, they're like, and we're done. So, so these are some things that, you know, have kind of unclear benefits. I have a lot of people take DHEA. It's converted to testosterone. It's pretty safe to take. You can get it at the drugstore. It's cheap. And again, some people think it's great. Other people think it does nothing, but that's sort of kind of a safe thing to try. So this is just an example of a patient that I would have. So patient comes in, has irregular periods, no history of STDs. This is that same, you know, patient from the beginning. And then we talk and we find out she's been married 20 years. She has an orgasm when she has oral sex, has vaginal sex, doesn't have an orgasm for that. Husband travels for work. They have a good relationship. Our biggest problem is initiation. So at 48, I'm thinking, okay, is this person maybe perimenopausal? Maybe they have low estrogen. Maybe sex is painful. Maybe that's what's going on. And I look and I don't see any of those things. So I talked to her about the ADI, but we both agree that sounds terrible. Using a vibrator, maybe we talk about doing a testosterone ointment, and we follow up in a couple months. And I find these patients, like, it takes several visits, obviously, to figure out, everybody's so different, what works for them. A lot of times they're not sharing with me all the details of what's going on the first time because I just met them or I haven't seen them in a year or whatever. So I find it takes a little bit of rapport to kind of get to what's really going on. And that's really it. You know, there are some other ways to dive deeper into this. I mean, obviously for all these things, but and then this is what my practice, especially with this topic, and I'm sure you've seen the slide before, but this is how it feels to me, is that I thought, oh, you know, sexual dysfunction, I'll read about it and then I'll just treat these patients and they'll get better and it'll be great. And then nope. So that's it. Thank you. I'm happy to take any and all questions. So
thank you.
Yeah. I think it's more anxiety. A lot of some of those patients, and you know, those are the least. Oh, sorry. I'm still on there, right? Yeah. So the question was about boost bar being on that last slide about for sexual dysfunction, and you know, I think it's more that a lot of these patients have anxiety, and those are better for libido than some of the other antidepressants. Yeah.
I'm curious about like what you think maybe the most effective way of taking the sexual history, like I think since going more toward the sex therapy route, I have the option in my practice to say, you know, I'm just gonna give you my standard intake, and then we'll get into the sexual history stuff in person. And I can see that being really good for some people, but maybe for other people, they might prefer to answer some of those questions initially in writing versus in person. So, I mean, if you had your brothers, would you do it usually one way, or would you offer patients like either option?
I would probably offer either option. And, you know, I mean, you know how it is when you see a patient and you're kind of looking for cues. Are they comfortable? Are they not comfortable? Would they rather just write it down? You know, if you start asking and they start getting, you know, and then you think, okay, maybe we'll just give you a little piece of paper. Yeah. So I think that's a great question. I think it's like I said, I've struggled with how to do that. I mean, some people get offended if you ask, you know, especially for me, because they're not coming in for those things. If I ask them, are you having sex? Yes. Do you have a partner? Yes. Is your partner male or female? You know, male, yeah, okay, well, I mean, I'm just asking, I don't, you know, no judgment, you know, so I do think it's a difficult thing to talk about and make people feel comfortable talking about it. Yeah.
So I find some of my long-term solitary clients who don't date.
Yeah.
It's a lot of it is fear of ecstasy, things like that. But then what happened this year, and maybe there's apparently it can be what's called a double vagina. Or double uterus?
Uh-huh.
What is that?
Oh, okay. That's a great. So the question was about what a double vagina.
Kind of like the idea was that I'm finding that people aren't like that. I send them to see you.
Yeah.
And we find out the reason that they stopped is because it was hurting. And then come to find out there was actually a genetic or
some other, yeah. Yeah. So that's not super common, but so what that is let's see, the best way to I guess describe how that happens is embryologically in women, the sex organ, they're actually formed in two halves that come together. So when you're formed with a vagina and each side of the uterus, and then each side, and then each ovary, and then they come together like this, and then the middle is supposed to dissolve. And so the imperfect hymen is an example of just the very end game, not dissolving, but sometimes they'll come together and that middle part won't dissolve, and you'll end up with two vaginas, two cervixes, and two uteruses. So that's called uterine didelphys. But then you have different extents to which that dissolves. So some people, it'll come together and the uterus part will dissolve, but the vagina part won't. And so they'll have two sides to their vagina. They'll have like a membrane in the middle, and then there's two cervixes or one cervix and one uterus. I mean, you can see kind of any combination of that. It's very easy to misdiagnose because, especially if they've had sex, what can happen is they're having sex on one side of that membrane and it's pushing that membrane over, and then no one's ever realized there's another side. I mean, this is really uncommon, so don't be thinking like, oh, all my patients have double vaginas, because they don't. But I'm just saying it can be really easy. I mean, because you think, how would you miss that? It's like, it can be really easy to miss. So, but yes, that's what that is. It's, yeah. Mm-hmm. Yeah, but it's interesting. Yeah. 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 Yes. Who are they? I could give you a list. I don't know that I could say off the top of my head, but I'd be happy to send you a list of them, and anybody can email me and I'd be happy to send you a list. It's a mixed bag. Yeah, typically not. So that's usually the biggest problem I have with it. Mm-hmm. Mm-hmm.
So yes. I wonder if you could talk about some of the downstream effects of the coming abortion bans.
Oh, yes. Oh, yes. The question was if I could talk about some of the downstream effects of the impending, hope possibly Roe v. Wade being overturned. So in our specialty, it kind of goes so beyond just the overturning of Roe v. Wade, because, you know, of course, there's access to care and access for women, but we have so many situations that would be impacted by this. And an example I can give is, you know, if a woman has an ectopic pregnancy and that ectopic pregnancy has a heartbeat, which happens a lot, how are we going to handle that? And am I going to be prosecuted for treating that. I mean, and I was giving this example to somebody earlier. I mean, currently Ascension, or St. Thomas Midtown, is owned by Ascension, which is a Catholic hospital. And so we are not allowed to do any kind of termination procedures. But when there is a patient like that, which I've had happen, we call their board, which is made up of the nuns and whoever else. And they always say, yes, obviously you need to take care of that for the life of the mother. But if these laws pass, I may not be protected, just by them telling me I can do that. There are also some, obviously we have all kinds of genetic and abnormalities that can happen with pregnancies. You can have fetuses that have no chance at living, but have horrible problems, either genetically, chromosomally, otherwise. And pregnancy is not a benign condition. Women die from pregnancy. We have abysmal maternal mortality rates in this country for our status in the world. So it's very scary to think about that. So regardless of even how you feel about the procedure itself and the elective termination of an otherwise healthy 10-week pregnancy, it's all the other stuff that is really scary for us in my field. Anything else? Yeah.
I'm curious about, I appreciate how personal centered you're being speaking about libido and, how individuals define that is. And I'm wondering about seeing folks who kind of self-identify as asexual in your practice. Is that something that you see often? And I don't know that I have like a specific question, but I just love to hear.
Yeah. I'm sure I do see those patients. I'm also sure they don't always tell me that, right? Because unless they perceive they have a problem around that may not come up. They'll probably just answer the question that they aren't sexually active, and, unless they have a specific question. So I can't say I would probably focus on that too much unless they had a specific problem, but I'm sure I see those patients. Yeah.
Could you repeat that last question, please? Could we repeat the last question, please?
Okay. You're welcome. Yeah, thank you.